not have full object constancy. So yes, that's what I would say. I would say that anyone who has DID is narcissistic level at best, and many of them are borderline. Now, certainly those folks would agree that many of them are borderline and that many of them are narcissistic, but they would still insist that there are some that are in the lower neurotic spectrum. And we just simply agree to disagree. I think the empirical data supports my view. Yeah.
An interesting comment on just what you said. If I am a few minutes late to follow one of my DID patients into my office, she decompensates to a 4-year-old. And this happened last week. She walked in as 21 years old. And I was talking with my office manager for a few minutes. I walked into the room, my office. She was on the floor sobbing her heart out. I said, well, what's wrong? She says, the teddy bear is not here, sobbing. And then I looked around and her teddy bear wasn't there that she had brought a year ago. The cleaning man apparently moved it to the snack room, which was nearby. So I think it's in the next room here. I gave it to her and she hugged it and calmed down real quick.
That's right. I think you point out how it is very characteristic of people who don't have full constancy that they cannot tolerate change, that any change in the environment, whether we're talking about a teddy bear that has been moved, or you painted the colors of your walls, or heaven forbid you work in a clinic where every day you're in a different office and you never know from day to day where you're going to be, or even if you shave off your beard, or change the color of your hair, or become pregnant if you're a woman. Those all can be disorganizing to that patient's ability to maintain an alliance because the disruption in the constancy. And when those things are going to happen, as they inevitably do, you have to anticipate and plan for them and often provide transitional objects or transitional phenomena to help patients move through them.
Well, temporarily she was well down the developmental spectrum. If I wasn't there right away, the alter that was out dissociated. The younger one came out under that condition of deprivation, sought the teddy bear. That's way down there in the transitional object developmental arrest area.
Mm-hmm. Yes.
So where would you place the eating disorders? A classic anorexic and bulimia. Where is she?
I did for a number of years I directed the eating disorder program at our medical school. And between 1983 and 1988, I did a 5-year study simply examining where patients who present with the 3 major eating disorders of bulimia, bulimorexia, and anorexia nervosa fall developmentally in terms of object permanence and object constancy-based variables. And what we found is most interesting. Across about 700 patients, we found that bulimic patients fall about 70% in the lower neurotic and 30% in the upper narcissistic range. That is to say, they seem to be right here around trying to consolidate full evocative object and self-constancy. For that reason, they still have a propensity to dissociation. We'll talk after the break about putting dissociative phenomena on this maturational continuum. For bulimorexes, the ones who have both anorectic and bulimic symptoms, they all fell in. And it was very nice that that corresponded with our hypotheses and maybe with your clinical experience. And if you're interested, that was published in the Archives of General Psychiatry in 1991. And it is entitled A Developmentally Informed Clinical Investigation of Anorexia and Bulimia. The Archives of General Psychiatry, 1991. Okay, why don't we take a quick break, and we'll come back around 10:30 and continue some more about techniques for working on affect, identity, and object relatedness. And also, one of our colleagues has some abstracts of a paper that she's going to be presenting that integrates some of these developmental notions with the work of Jung and some of his people. If you want to raise your hand so everybody can see you are. So if you're interested, she has generously agreed to share some of these abstracts of the paper. You would like? Great. I'll see that you get it. Thank you. Yeah. Now, kind of on how you define imagination. We certainly have reason to believe from some of Jerome Singer's work, and particularly Benjamin Stern's work, that infants as young as 2 or 3 months may be having imaginings, although at that point it's hard to know what the nature of that imagining is because you can't ask what's happening. You know, are they more like dreams? Are they more like hallucinations? But there seemed to be some internal representation of experience that gets repeated, and which is available for, quote, remembering and learning and imprinting, or however you want to think about it. And so I would say that even in the psychotic range, we can use imagery work, but the nature of the images may be somewhat different, both in terms of the affective elaboration and sort of the formal construction of the images. So I'd say that there is imagery. There is a capacity for doing imagery work. Now, a sort of different question is, can you do imagery work with people who are acutely psychotic? Not necessarily arrested at the psychotic level, but perhaps schizotypal or borderline developmentally, but who have a schizophrenia or some other kind of psychotic condition which causes them to be acutely psychotic. And we're talking now then psychotic in a clinical sense, not in a developmental sense. And the answer is yes, you can do this kind of imagery work. In fact, some of you may know that most of my early work was primarily on using these kinds of techniques specifically with schizophrenic patients. And one of the studies that we did is that we took first break acutely paranoid schizophrenic patients. And we did some hypnotic work with them to establish a transitional object representation, and taught them to use that as a cue whenever they began to have auditory hallucinations. And then in a single blind rating, these patients had fewer hallucinations than those who were treated with antipsychotic medication. And obviously no side effects. That is to say that the transitional object cue, very neuroleptics when this study was done, I mean, I'm neurons now, but in the control of hallucinations. And that was published in the Archives of General Psychiatry in 1979. So you can do this sort of work with schizophrenics. Yeah.
Yes, I would like to add some comments about this interesting issue.
Yeah.
Recent study with neuroimaging have shown that different parts of the brain can be activated in case the person is asked to see something, which is the occipital region of the brain, or the parietal region of the brain, and to imagine seeing something. In this latter case, is the prefrontal and orbitofrontal region of the brain which is activated. So, and mainly in the right brain rather than in the left brain. So it could be possible and feasible to study infants to see whether in the supposed imagery state the frontal or orbitofrontal lobe are more activated than other regions. This could be a kind of a neurological correlate of what we are talking about.
Yeah, that would be fascinating if there could be that kind of. And is that predominantly PET scans, PET
yes,
scanning?
yes,
Yeah.
yes. We can also do with SPECT, but it's less accurate. So you need.
Yeah, fascinating. That would be very interesting to do with infants.
And also hallucination.
Yeah.
So they are considered now as a kind of self-generated image from part of the brain.
Yeah,
So.
very interesting. Okay, well, why don't we move ahead? I'm not going to spend a lot of time on a couple of handouts included for you because I think they're self-explanatory. But I just wanted to direct your attention to them. The first one is hypnotic strategy and technique. This, I think, also appears in the handouts that you got from Reg. He had put them in there. But this describes some of the specific ways that we might use hypnosis with patients at the psychotic, borderline, or neurotic level, and some specific alterations in technique, particularly around induction and trance management, that are necessary for working with patients at each of these levels of development. You may ask, well, where are the schizotypal and the narcissistic? And I think you could imagine that the schizotypals, when they're doing well, are more like borderlines, and when they're not doing well, are more like psychotics. The narcissistic, when they're doing well, are more like neurotics, and when they're not doing well, they're more like borderlines. So this may be useful to you in examining some of the specific reasons why we would do hypnosis with these patients, what we would do it for, and what alterations would we need in technique for working with patients who are pre-neurotically organized. So you have that handout. The other handout that I wanted to mention to you is one entitled Treatment Foci. And this applies actually not just to hypnosis, but to psychotherapy as well. And what I've attempted to do here is for patients at each of the levels of maturity, which you see along the left-hand column of the page, the neurotic mature level, the narcissistic level, the borderline, the schizotypal, and the psychotic, to list what are the structural issues that become the focus of therapy, what are the problems in cognition, affect, capacity for interpersonal involvement, identity formation, and defensive blocks that need to be attended to as a function of the structural arrest, so that those can kind of guide your treatment planning as you think about choosing developmentally focused interventions for patients at each level of maturity. And although we're not going to talk a lot about it, I frequently get a lot of questions about working specifically with borderline patients. We could do a whole workshop on treating borderlines, or a whole workshop on treating psychotics, or a whole workshop on treating narcissistic spectrum disorders, and I do often do those. But I get a lot of questions about borderlines because I think they are so troublesome to many of us. And so I included in your handout intensive psychotherapeutic strategies with borderline patients. And here what I have done is listed in a kind of chronological order, moving from the most primitive to the least primitive, the structural problems and difficulties in treating these patients that need to be the focus of psychotherapy, specific goals for intervention, and strategies for achieving those goals. And I would generally pursue this in this kind of a hierarchical fashion. So you may find that useful to you as you think about working with borderline patients. I don't want to advertise myself, but several of you did ask me, do I ever teach other places? And if so, you might like to know about that. And I certainly often teach at ASCH or SCEH. I am going to be teaching a workshop at SCEH. Some of you may not know the Society for Clinical and Experimental Hypnosis, which is the older of the two American societies of hypnosis, from which ASCH divided off in the early 60s. I will be teaching a workshop there in November. We're meeting in Washington. And I'm teaching a more general workshop on psychotherapy, the Society for Clinical and Experimental Hypnosis. And if you're interested in information on that meeting, you can write to the Society offices, which are located in Indianapolis, Indiana, or you can just call.
Washington, D.C., Dr. Baker?
Yeah, that's where the meetings will be held this time. And then I am teaching, I each year teach a series of workshops at Menninger's. Some of you know the Menninger Foundation in Topeka, Kansas. And you could write continuing education there. In September, I will be teaching an introductory workshop, which would not be of interest to you, but the following May, almost a year from now, not quite, I'm teaching a 3-day workshop on hypnosis for character pathology, which you might find interesting. So you could write continuing education. And then
Topeka,
yeah, Topeka, Kansas.
September.
Yes, in September is the introductory workshop, but next May is the more advanced one.
Next May.
Yeah.
And Washington is November? Or
Yeah, November.
Are there any overseas activities on your part?
I do often teach in Europe, and I can't say that I have a trip planned anytime soon, but I'd love to be invited. Usually every other year I end up in Europe, and I don't have any plans for the rest of this year to be in Europe, but I would like to go. This seems to be my South American year, and I am going to be in Brazil and Argentina in the wintertime, and in Mexico next spring. And then I teach in many parts of the United States, and many of you have given me your card and said that you'd like to know where I'm going to be. So whenever I'm going to be someplace where it's sort of near people, I put your cards on my computer, and I always ask the local arrangements folks to send you an announcement if you are interested in it. So. And then other people ask me if I ever do telephone supervision or consultation. And the answer is yes, and if you're interested in talking about that, I'd be happy to do that, and just take my card if you haven't already, and you can give me a call and we'll discuss it. So, you had a question?
Besides that one outline for clinical technique, do you have any more reprints of actual imagery and suggestions?
They appear in many of my articles, but I don't have any other ones that I think are specifically relevant that are not in those articles. And most of the articles that would be relevant to what I'm talking about, Reg put in the bibliography that is included in the handout to you. So you'll find in there some imagery on affect regulation, some imagery on self-concept formation, some imagery on capacity for object relatedness, imagery on self-wholeness and body wholeness, are in some of those articles that are cited there.
Or you can match them up to certain occasional stages, critical
Yes.
stages of development.
Yeah. Okay, well, why don't we move ahead then and begin to talk about some specific issues of technique now that we all have the conceptualization down. There are a couple of areas that I wanted to touch on in particular, and the first of these is affect regulation. So many times the problems that we have with pre-neurotic patients are problems with managing acting out and impulsivity, or in managing dissociative phenomena, or in managing self-mutilation, or in managing somatization. And all of these symptoms, by and large, are the response to unneutralized affectivity, which is overwhelming to the person because they do not have the structural capacity to contain and modulate it, and haven't developed maturationally the shift from unneutralized to neutralized affect. So when patients present to me with specific symptoms around acting out, or around dissociation, or around somatization, who are pre-neurotically organized, the first thing that I begin to think about is how can I access and help to neutralize the underlying affect which gives rise to the need for this particular symptom. And let me tell you how I'm using the term unneutralized so that we can have the same language. When I say unneutralized, I'm really contrasting it to neutralized, and using it really in the sense that was most made popular by the ego psychologists, and in particular Heinz Hartmann. Many of you may know Hartmann is thought of as the father of American ego psychology, and his classic monograph, published first in 1946 and then again in 1949, The Ego and the Problem of Adaptation, is considered to be sort of the Bible of ego psychology. It has many of the fundamental tenets of ego psychology explicated there. And Hartmann distinguished between neutralized and unneutralized affect by saying that unneutralized affect is overwhelmingly intense, elaborated in an archaic and primitive fashion, disorganizing to the individual, and experienced as ego dystonic, as not a part of me, as something that is threatening to the integrity of self. Neutralized affect is just the opposite. It is affect which is modulated and not overly intense, which has been filtered through secondary process, so it is not primitive and archaic in terms of its cognitive elaboration. It is vitalizing to the self rather than threatening to the self, and experienced as egosyntonic, as a part of self. Okay? For most of us, as we become more mature, our affect is not frightening. Our affect is the source of our passion, of our creativity, the vitality of life. Nobody, I think, would like to live emotionally anesthetized. But pre-neurotic patients do want to be emotionally anesthetized. They do many things to try to anesthetize their affect because their affect is characteristically unneutralized. And as their affect intensifies, they feel frightened and they feel overwhelmed. And this is the precipitant to the formation of many of the symptoms which they present clinically. So how do we go about moving affect from being unneutralized to being neutralized? And again, following this kind of developmental model, what I have found most useful is to try to think of how can we recapitulate the normal maturational course as it has been described by numerous theorists. And again, I have found particularly helpful the outline proposed by Hartman, who described 4 stages or 4 mechanisms by which affect is neutralized. The first of these is containment. The second is modulation. The third is symbolization, to which I referred to earlier this morning. And the fourth is integration. So containment, modulation, symbolization, and integration. Let's talk a little bit about each, about what they mean and what some hypnotherapeutic techniques are which would be useful in achieving each of them. Okay. Containment is used here really in a kind of Winnicottian sense, in the way that Winnicott describes the holding environment as containing and securing for the infant. And when Winnicott observed what mothers do with their infants, he said that when the mother picks up and holds the child, there are a number of things that happen. One of the things that happens is that there is a sensory affirmation of boundaries. That is, the mother's arms wrapped around the child helps to give definition to the outlines of the child's body. And that there is, in that sense, a boundary affirmation or stabilization function of containment. Also, as the child is held in space, there is a sense of warmth and security and attachment. Because while the mother is holding the child, there is research that shows there is even oftentimes a synchronization in breathing and so forth. There's a kind of empathically fueled attunement which is occurring. Okay? So when we think about containment, we want to think about how can we affirm the boundaries of the individual, create a secure, anchoring environment where there is a sense of safety, and where there is a sense of attachment and empathic attunement uninterrupted by the expression and discharge of affect. That into this place, into this sort of metaphoric relational container, the individual can discharge and abreact their affect without a loss of differentiated self, without a loss of security, without a loss of attachment. Okay? So when we think about providing the containing functions for our patients in psychotherapy, that's what we want to do. Affirm their boundaries, help them feel safe, hold the consistency of attachment in the face of affective discharge. Makes good sense. I think we all probably try to do that, even if we don't conceptualize it in just that way. But thinking of it in that way begins to suggest to you some specific hypnoanalytic interventions that we can utilize to affirm the boundaries of self, okay? To do that kind of sensory anchoring in the boundaries of self. One of the things that I find very useful is a kind of variation of moving hands, to move their hands together, to allow the hands to clasp tightly together, to feel the right hand clasping onto the left hand clasping onto the right, to hold them very tightly together, and in that togetherness, no matter how tightly they squeeze, they can feel that their right hand is still connected to their right arm, that their left hand is still connected to their left arm, but there is a sense of strength and a sense of warmth that develops as those hands are tightly clasped. And the tighter the clasp, the stronger the sensation, the warmer the warmth. And when they're ready, they can allow their hands to relax, to move back to rest again on the arms of the chair, to see that their right hand is still their right and their left hand is still their left. Okay? Now, one can then say, and in that same way, as we come together in psychotherapy, in that togetherness you can feel a kind of strength and a kind of warmth. And no matter how intensely, how strongly we work, that sense of you being you and me being me will not be disrupted, just as your right hand is still your right and your left hand is still your left. And in that togetherness, you can feel the strength of our alliance and the warmth of our attachment, just as you could feel your right hand clasping tightly onto your left and your left clasping tightly onto your right. And when you need to move away, when you want things to become more quiet or distance again, you'll still be you and I'll still be me. So we have a real sensory motor anchor for this notion that two people can come together and not dissolve into one another, not lose the distinct separateness of their identity. And in that togetherness, there can be the experience of intensity. But that intensity can be understood as strength and warmth and attachment, and will not in any way interfere with the ability to be separate and differentiated. Okay? Yes?
How deep is the hypnotic trance when you utilize that?
I think it's variable. I by and large let my patients control the depth of trance for themselves, as most people do. Typically what I would do would be some induction and some deepening, and then I might move into this. But I don't say do some sort of age regression or try to evoke a very deep somnambulistic trance. If the person then appears to become anxious or be alerting in the midst of doing this, I stop, inquire what's going on, do some more deepening or do some more relaxing, and then help the person to re-engage the experience again. Your question invites me to take an interesting aside, and I don't want to get too far from what we're talking about. But just technically, let me say a couple of words about what deepens trance, because one of those components is really the more important issue here than depth. My understanding of most of the research literature on what deepens trance is that what deepens trance is compliance and alliance. That is to say, that all the things that we do to help people become more absorbed in their trance experience involve either evoking something that they then will experience, will comply with, and or evoking a sense of our being together as we tune into them and as we take them to a place that we've already described, suggesting that we are already there, and coming to that place means coming to be with us in that place. Now, I say that because what is particularly important in doing this kind of work is the sense of alliance. So it's not so much how deep is the person, although that is a kind of side effect, if you will. Is the alliance vital? And I know that yesterday Reg talked with you some about the nature of the therapeutic alliance. But one of the very interesting ways of understanding it is that if we imagine that some aspect of the therapeutic relationship is transferentially derived, and some aspect of this relational matrix is non-transferential contemporary, then as the transference grows, we have this kind of center interactive area, which is informed by the regression of the transference with the affect that it brings, and contained and made sense of by the non-transferential aspects of the relationship. This is the alliance. So the real question to ask is, how do you know when you can do this kind of structure-changing work? You can do this kind of structure-changing work when the balance between the transference and the non-transference is appropriately titrated so that the alliance is phenomenologically near. So that's the real question. Not how deep is the trance, but how vital is the alliance. And if the alliance is vital, both in waking psychotherapy and in trance therapy, because as you know, that when we introduce hypnosis into psychotherapy, we always get a splitting of the phenomenological field. And when we are terminating hypnotically potentiated psychotherapy, we have to reintegrate that split. But when we have a good alliance in trance, usually signified, at least initially, by the person's readiness to enter trance with us, and willingness to let us track with them. And a good alliance in waking psychotherapy, signified by our ability to track the patient and empathically attune the patient and bring our countertransference and their transference into a mutual alignment, then we can do this kind of structure-changing work. Then we can do that, bringing your hands together, or any other sort of developmentally evocative intervention.
When the balance is titrated between contemporary and transference, is that when they're equal? Is that what you're saying?
Well, I don't know that they're necessarily equal. It's when they are maximally facilitated. And for different people, the amount of titration is different. For instance, I don't want to get too far off talking about this, but it's an important issue. If you have a patient who starts out who is psychotic, let's say, then much of how they experience you and respond to you is going to be contaminated by transferentially derived projections, externalizations, displacements. Okay? And the contemporary is not going to be very much. Okay? So we may need to make the contemporary grow a lot in order to develop a sense of alliance. Minimize the transference, contain it. Okay? If you have someone who's starting out who is neurotic and very constrictive and compulsive and rigid, then they may not tolerate very much affective intensity or regression. And the transference may be just a little bit. And so we have to work a lot to increase the transference in order for there to be enough regression and affect to fuel the analytic work. Okay? For borderline patients and narcissistic patients and schizotypal patients, sort of between here and here, it's a lot harder than that. We know how to focus on the here and now and provide structure and direction and minimize the transference. We know how to facilitate transference-based regression. With these folks, we're always walking a tight wire. A little bit of transference over here, a little bit of containment over here, a little bit more affect and regression, a little bit more containment and direction. So it's closer to in the middle, equally balanced, if you will, for this middle range of folks. But the thing that's interesting is that when you are working on this side of object constancy, with borderline and schizotypal patients in particular, the contemporary comes mostly from the observing ego of the therapist. That is to say, from the therapist's ability to use their empathy to develop the container. Okay. All right, so containment, yes.
The problem, it seems to me, is, for example, if you're working with a multiple who has a lot of child parts, once you get into that kind of strong, intense alliance, how do you convince the child part of the system to move to the next step?
I think because, at least in my work, I direct my alliance predominantly to the host, or to the central self. And I try to strengthen my alliance and test my alliance with the central self. And I view the emergence of these alters, even though necessary, as disruptions in the alliance that are responses to unneutralized affect evoked by the transference. That they come out in the therapy hour at that particular moment because of the influence of the transference. And that, therefore, in order to restore the sense of alliance with the central alter and incrementally move one small bit more towards integrating that self, one has to titrate that transference so that one can remove the blocks to restoring a vital alliance. So at that point, I wouldn't work to establish an alliance with the child. I would work towards returning to my alliance with the central self or the host self by titrating the transference-based affect and neutralizing that affect in the service of restoring some incremental integration to the central self that hopefully grows. Each time this happens, it has to happen 1,000 times or 10,000 times because these alters will come out. They have to be dealt with. Or more directly, one has to deal with the affect they contain. I mean, the reason there are alters is because there is overwhelming affect that had to be put someplace. And so what you really need to do is, as you neutralize each tiny bit of affect which they bring, each time they come into conscious awareness or your presence, then you're gradually reducing the need for them, and they can gradually then be reintegrated into the central self.
Can I say one more thing?
Yeah.
If you work with people, especially multiples, and you're not their first therapist because they've gotten completely mucked up in other therapies, what you find is a tremendous attachment to the previous therapist, usually by the less developed parts of the system, and then you spend a tremendous amount of time trying to untangle that.
Absolutely, and the reason is, as I understand it, is because those people have not adequately attended to managing the transference. Or said differently, they have not appropriately established and maintained the therapeutic alliance. Oftentimes out of their own countertransferential need to protect the vulnerable little ones. And so they form their alliances or enact the transferences with those little selves, and in that sense fuel them, and fuel the splits and the dissociative defenses which protect them. And that happens all the time, you're right. Well, let's quickly move along. We've got a lot to cover here. In containment then, what we want to do is to provide for the person a relational place that is safe enough to discharge, and then to experience the integrity of boundaries, and then to, in imagery, practice different images of things that are big enough and strong enough and durable enough to hold whatever they need to hold. Trunks that are big enough, baskets that are big enough, pots and pails and pans and closets and safes, whatever you need for them to have. I wish that I had time to tell you about some interesting cases that I have, but I think you can get the idea if I simply mention to you I have one patient for whom their affect is so powerful that we've discovered that the only thing that is safe enough to contain it is a safe, a vault, buried in 20 feet of concrete underneath the Rocky Mountains, protected by 20 different locks, each having 20 different combinations. You know, that's intense. But that was the only container that felt big enough. But once they could construct that in their imagery, then there was a sense that there was an experiential place that could contain. So containment is really very literally enforcing the container, the body container, the relational container, and the cognitive imagery containers. Okay. The second step is affect modulation. Here again, hypnosis has a great deal to offer. We have for many years had many techniques for managing the intensity of internal affect. We usually think of them as tension reduction strategies, but they can be applied to any sort of affect, whether the tension has to do with anger or with anxiety or with dysphoria. We can teach our patients here strategies for reducing the intensity of their affect, whether it is relaxation strategies or imagery strategies. One of my favorite images to use for modulating affect has to do with the old notion of turning down the thermostat dial, turning on and off the light switches, techniques that you learned in the introductory workshop, but are really very powerful. But also I like Dan Brown's work. Some of you may have read his work on affect modulation. And he talks about helping the patient develop a safe place. Oftentimes he uses the image of a bubble that has very powerful walls where the person can see out but can control what gets in. And the person can imagine taking into that protected glass bubble all the things that they'd like to have there to feel safe and soothed and nurtured and anchored. But that becomes a very nice imagery. So you can teach imagery strategies. You can have people discharge through fantasy, either symbolic fantasy or more direct fantasy. I mean, they can imagine beating the hell out of somebody. And in this sense, some of the silent abreactive approaches, like Helen Watkins, or some of the other abreactive approaches can be useful as imagery-mediated affect dischargers. The important thing is that with pre-neurotic patients, the particular elaboration of this is threefold. whatever of these techniques you use, which you would use technically the same as you have learned how to do it with neurotic patients, we need to incorporate 3 additional steps. The first is that the person is able to maintain a sense of the permanence, wholeness, and constancy of self in the face of approaching affect. That is to say, that you suggest, reaffirm, reassure, if necessary, provide cues or opportunities to test, that self stays the same, that self is not destroyed by letting go of affect or by abreacting affect. Okay? The second thing is to make sure that the alliance continues, that the discharge of affect does not evoke some negative elaboration of the transference which interferes with the sense of alliance. So I usually precede this work by evoking a sense of connectedness and closeness and empathic attunement, and follow this work by re-evoking that same sense of connectedness and positive attunement. Having the person see the two of us together doing something that feels safe, that feels nurturing, that feels protective, that feels reinforcing. Yes?
Do you, in effect, begin and end your trance work with reference to you and the patient?
Yes, exactly. Yes, building the alliance in that way. First in the service of deepening, but also in anticipating any affect-related work, and then following any affect. If I've done affect modulation or affect neutralizing work in the trance, I would precede and follow the work by evoking the sense of alliance.
When you get into the specific imageries, then, do you have the patient leave you, or are you there with them the whole time, or how do you transition from beginning the trance with you there and ending with you there? Where are you in the...
I'm always there.
Okay,
I'm
so
always there, because the sense is that once the experience of being with me, once the experiential referent has been established, we hope that it is the experience. What we try to create with hypnosis is the experience of being safe, of being protected, of being soothed, of being nurtured, all the things that hypnosis typically is for people. That then becomes a part of their inner representational world. It's there forever. They can remember it, they can recall it, they can evoke it whenever they wish for self-soothing. And as they move increasingly to have permanence and towards constancy, that can become a post-hypnotic cue for all kinds of things, for reinforcing post-hypnotic suggestion compliance, for instance. Let's say that I would have a pre-neurotic patient that I was working on smoking cessation in the midst of this work. One of the things that I would say is, let's say I give them the cue that each time that they find themselves wanting a cigarette, they imagine a stop sign, and the wish for the cigarette can disappear, can be reduced. I would then add, and each time that happens, you can feel the same sense of comfort, the same sense of safety, the same sense of being understood and secure that you feel here in my office with me today. That is to say, we're evoking the internalized experience of the alliance as a reinforcer of the patient's own strength. The idea being that the experience of being valued and anchored by the other is internalized and eventually integrated into the patient's own sense of valuing herself or himself, of being himself or herself strong. In other words, in some sense, you all know the old Ericksonian rub that my voice will go with you. My approach is rather that you shall find your own voice, first as an echo of what you hear, and then as an expression of what you become. We want patients to have their own strength, and just like with our children, their sense of self begins with how we treat them. If we treat them like they're crap, they think they are. You know, this was sort of the central notion of Sullivan's concept of the malevolent transformation. He said that if you treat people like they're crappy, they don't necessarily conclude that there's something wrong with you. They think there's something wrong with them. Why? Because it's more hopeful. If they think that you're unable to love, to understand, to protect, there's no hope of ever getting it from you. But if they think that you're not loving and protecting them because they're not big enough, good enough, pretty enough, smart enough, strong enough, there's always the hope that if they become good enough, big enough, smart enough, then you'll love them. That's the malevolent transformation, the distortion in identity in the service of protecting the wish, the fantasy, that somebody somewhere will love me enough. But the important kernel here is that the way that we are treated informs how we treat ourselves, and how we are seen by others informs how we see ourselves. So this notion that the patient is internalizing the representation of us comforting and soothing and anchoring them first helps them to feel deserving and capable of being comforted and soothed and anchored, and then becomes the basis for their emerging capacity to provide that for themselves. Okay? So affect regulation, the second step. The third, symbolization. This we've already talked about to some degree. It's giving words to the experience. Now, sometimes a way station along this route is that the symbolization has to be non-linguistic. Some people can't jump right away to words. In the beginning, they have to symbolize their affects with colors, or with sounds, or with numbers, or with more symbolic kinds of words. I have a very disturbed multiple personality that I'm working with right now, and the best that she can do is say, I feel black, I feel purple. And we've even worked for her to have certain transitional objects that she uses as post-hypnotic cues that allow her to shift the intensity of her affect by changing the intensity of the color. She takes a piece of paper and she makes it very, very dark with a colored pencil, and then she can gradually erase it. Okay? And the erasing becomes a kind of self-soothing activity, so that initially she's feeling overwhelmed by how angry she is. But by the time she finishes this, the repetition is evocative of the repetition of transinduction. And the pencil is evocative for her of the pen that is in my pocket. So by calling forth, evoking this representation of me, and this partial representation of the process of trans-involvement, she's learning to reduce the intensity of her anger in between the sessions, and therefore the need to shift to an alter, to dissociate. Also, the experience of rubbing this pencil across the paper and observing as it lightens is a sensory anchor which connects her to the external environment, exactly the opposite of what provokes dissociation. If any of you back in the 60s went to a stimulus deprivation tank, you know that one of the things that often happened is you dissociated. People dissociate as they remove themselves from connection to the external environment. That's what we do in transinduction. Okay? But by reconnecting them to the external environment through sensory anchors, listening, looking, touching, rubbing, we can help them learn to control their dissociation. And we'll come to in a moment to specific techniques for managing dissociative pathology. But they are really based on planting these kinds of sensory anchors which reverse moving away from the world to re-engaging the world in a sensory fashion which prevents dissociation from operating. Okay. So symbolization then, giving words to, labeling the affect, imagining seeing it written down or represented in colors, colored down, seeing it written on a blackboard, erased or lightened. I like to use the image of those little sheets that are on clipboards that children often have, where you can write something and then pull the sheet up and it disappears, and you can make it go just part away or all the way, and you can do it slowly, you can do it very fast. So you can modulate in different ways your management of that symbol. So being able to symbolize, having the person imagine writing in a diary or writing on a piece of paper, and then moving from that to be able to talk about, and then to express verbally the affect, first in the context of therapy in imagery, and then rehearsing in fantasy, expressing the affect across various situations with different people and different affects, while maintaining a sense of comfort, calm, and the ongoing security of self-representation. Okay. And the final step is integration, which this last component of symbolization really anticipates. And that is that the person can recognize that this is my feeling, and I can own this feeling. I can own its experience, and I can own its expression across relational and temporal and situational environments. I can see that this is me, and that I continue to be me when I'm angry with my wife, when I'm angry with my mother, when I'm angry with my boss, when I'm sad with my wife, when I'm sad with my mother, when I'm sad with my boss, when I'm anxious with my mother, when I'm anxious with my brother. That is to say, through directed, guided fantasy, you help them to see this as being a part of self, and that the characteristic expression of the affect is an affirmation of self rather than a threat to the integrity of self. Okay. Now, obviously, again, we don't do all of this in one session of hypnosis. If the patient is anxious, if the patient can't continue, we stop, we restore some sense of comfort, we explore what's going on if necessary, we bring it into waking therapy and work with it a bit interpretively or in an exploratory way, and then we re-engage the work in hypnosis until the person can complete this neutralization progression around a particular affect state, which gives rise to the need for the symptom which is disruptive to their functioning. Usually, it takes somewhere between 6 and 10 sessions. But those are 6 or 10 sessions that may be spread out across 15 or 20 sessions because they're interspersed with talking about, with conscious processing, what has occurred in the previous sessions of hypnotic work. Okay. Well, let's talk a little bit then about dissociation, because of all of the problems of pre-neurotic patients that stem from unneutralized affect, dissociation is especially disruptive. And we think of a number of different problems that are associated with dissociation, including multiple personality disorder, or DID, and many forms of acting out. For instance, I think most of you probably by now know that for many of our borderline patients, acting out is often in the form of self-mutilation. And that self-mutilation is itself an effort to reverse dissociation. If you listen to what happens to these folks before they self-mutilate, what they will often describe is that there's this growing sense of tension or affective intensity, although few of them can call it affective intensity initially. And even fewer can say, I get more and more angry and more enraged. But there's this increasing sense of internal affect. And then there's a sense of disconnection. And that disconnection is frightening because it suggests being destroyed or annihilated, being not real. Okay? What they're really describing is a kind of regressive route from distanciation to secondary dissociation, to primary dissociation, to depersonalization, to derealization, depending on how far they regress along the continuum of dissociation before they're able to restore some sense of control. Usually for people who self-mutilate, it's right here, because the fear is that they will cease to be real. They'll cease to exist. And so we see then the self-mutilating as a kind of sensory anchor. If they can feel the cutting, if they can feel the wetness of their blood, if they can feel the burning, then they can feel real. They can restore a sensory connection to the real world. If they can see their blood, or see a blister, or the charring away of skin, or the peeling back of flesh, they know that there were boundaries that held that in before. And rather than feeling pain or fear, they feel good. They feel re-anchored in a sense of reality. So all we have to do, basically, to manage this dissociation is to teach people an alternative sensory anchor. And one of the best ways to do this is in hypnosis to pair a sensory anchor with some transitional object representation which is evocative of the sense of alliance, and teach the person to use this as a kind of post-hypnotic cue. that whenever they feel themselves beginning to kind of space out, that is, as their affect intensifies before we can do all the affect neutralization work so it won't be overwhelming anymore, when they're kind of right in here, then before they move towards primary dissociation and depersonalization, they can use that cue and re-evoke the sense of alliance to reestablish their reality, their security, their capacity to contain, which is an extension of the therapeutic alliance's ability to secure and comfort and contain the overwhelming affect. So what I might say, for instance, is that whenever you feel yourself beginning to be overwhelmed in this way, I would say this while they're in trance, all you need to do is rub your thumb and finger together. Feel the texture of your finger rubbing your thumb, the feeling of your thumb rubbing your finger, the two fingers together, the way you and I come together sometimes, and form together a container for all the emptiness inside that can be just okay, that can make things feel just fine, that can remind you that just how thumbs can grasp and hold, and hands can greet and make friends. That this touch is a reminder of your ability to hold on to the external world, to make friends with the scary parts of you that feel too awful now to tame, and stay whole and safe and connected. And when you do that, not only will you feel firmly connected to the world, aware of all the things that you can see and hear and taste and smell and touch, you'll feel again the same sense of security and soothing and safety that you feel here in my office when we work together each time you come in this special way. Okay, so you can hear what we have done is that we've given a kind of sensory cue that is evocative of that sense of mastery and that sense of alliance, and which reverses feeling numbed out to feeling aware, safe enough to stay connected to all the things that you could see and all the things that you could hear and all the things that you could touch and so forth. And whenever patients present to me with dissociation early on, before I can do the affect neutralization work, I move ahead to teach this particular technique in an early hypnotic session for controlling the dissociation. Yes?
What's the difference between primary and secondary dissociation?
I'm glad you asked. I meant to say something about that. This is a distinction that actually was made by Freud when he first described dissociation in Chapter 7 of The Interpretation of Dreams, his classic work. And he said there are two kinds of dissociation. Secondary dissociation is when the person feels disconnected from the external world, that what is inside is no longer interactive with what is outside. This, he thought, was part of the general phenomenology of everyday life. We all engage secondary dissociation when we daydream. If you are sort of bored with my lecture, you could be thinking about where you're going to go to dinner tonight or what's going to happen when you go back home. So what you're focused on inside is no longer interactive with or connected with what's happening outside. It's withdrawing from the external world. That's also the kind of dissociation which is characteristic of light stages of trance. Okay? Primary dissociation is when aspects of the internal world are disconnected from other aspects of the internal world. Primary dissociation is more pathological. It's what we think of as being characteristic of dissociative disorders, that there are structured internal experiences which are split off from other structured internal experiences, and they are not easily put back together. Usually those structures, we believe, are established in order to contain affect, to protect some central part of the self from being overwhelmed by the intensity of affect that then gets sort of split off in these dissociated containers of experience. There's a wonderful paper in the Bulletin of the Menninger Clinic from 2 years ago where if you could imagine that this is the stream of consciousness, the author, John Allen, talks about you don't have access to the stuff down here. This is primary dissociation. Primary dissociation disrupts the stream of consciousness, or said more structurally, it disrupts the integrity of self, because aspects of self-experience have to become disconnected from other aspects of self-experience.
Do you make distinction when you talk about splitting between horizontal and vertical?
Sure, I think that's a useful distinction. And dissociation is itself not the same thing as splitting because it's a more dynamic, defensive phenomenon, whereas splitting we think of as a structured maturational phenomenon. But yes, we can talk about horizontal and vertical splitting, splitting of objects and splitting of self and so on and so forth between good and bad and whole and part. I think that's useful. Well, let's shift a little bit then away from talking about affect regulation and say just a couple of words about the maturation of identity and the maturation of capacity for object relatedness. In reality, from an object relations point of view, the two are very much connected to one another. That is to say that the experience, the differentiation, the integration and stabilization of self is parallel to one's emerging capacity for object relatedness. But one of the things that I put on the maturational timeline, which is in your handouts, your version of this drawing, is that I listed for you the maturational sequence for the development of identity, moving from self-differentiation and self-definition to self-stabilization. Issues that are important here in the psychotic, schizotypal, lower borderline range. That with the development of permanence comes the ability to differentiate and define and stabilize the self. Okay? And then in the borderline spectrum, issues of self-agency and self-control and self-regulation and self-soothing. These are the aspects of self that become focused and prominent, and largely are impacted by our work on affect neutralization. So if we were to imagine beginning to work with someone who is arrested down here at this level of maturity, beginning to work with object and self-permanence, with the development of boundaries, would lead directly into images around the differentiation, definition, and stability of self across time, space, and relational involvement. Then as we moved next to affect regulation, we would concomitantly be working on experiences of self as capable of self-control and self-agency, self-regulation, and self-soothing, usually developing in that particular order. You might ask, what is the difference between self-control and self-agency? At least as I use those terms, self-control has to do with the ability to modulate internal experience. Okay? Self-agency has to do with the sense of having power in the world. One has to do with self-regulation. The other has to do with an increasing capacity for alloplastic adaptation, for impacting the environment, for having control over the contingencies of self. So as one is working to contain affect at this level, modulate affect at this level, symbolize affect at this level, and work to integration into the lower neurotic range, one is simultaneously working to develop self-control and self-agency, self-regulation, and self-soothing, in anticipation of healthy self-esteem, and self-expression. Because the problem of self-expression is not only blocked by the false self at the narcissistic level, but by repression and constriction and the rigidification or coarctation of character defenses at the neurotic level. So the problem of self-expression is also the problem of individuation, how to freely and fully express the uniqueness of self without blocks about certain aspects of self. So we move then from a sense of internal control to having control over the world, to being able to regulate the self internally and externally, and to soothe oneself when that regulated state is disrupted either internally or externally. And with then our focus on constancy, we can focus on issues of self-esteem and eventually self-expression. So the elaboration of identity across the maturation moves from differentiation to integration, from definition to healthy esteem. And just as the lack of boundaries down here, because of the failure in object permanence, is a block to having a differentiated and defined sense of self, the lack of cohesion at the narcissistic level is a block to self-esteem, but elaborated in a particular way that I want to spend a couple of minutes talking about because it is so problematic. And that is the specific use of the pathognomonic false self. And I say pathognomonic here because the presence of a false self is seen as a signal criterion of narcissistic level phenomenology. And I think we all have experience working with narcissistic patients. I don't want to elaborate too much the theory about the false self, but simply to say that the false self is this kind of facade which has been erected and which is dependent on the presence of what Kohut calls self-objects to be maintained. And self-objects are essentially those objects which affirm the self by serving the function of mirroring and idealizing this false self facade. And as long as the narcissistic character can people his or her environment with these self-objects, that false self facade goes along okay, and we usually don't see them clinically. When they come to us is when these false self-structures have been injured or penetrated by the failure of external others to mirror, affirm, and idealize that false self with all of the propensity to seek grandiose fulfillment through omnipotence and manipulation and entitlement, which we all know is really a defense against the more basic underlying structure of vulnerability, and with it the phenomenology of emptiness and unworthiness and powerlessness. Hypnosis is really helpful in many ways in working with the false self through a variety of specific interventions. One of these is through images of mirrors. At least at a phenomenological and preconscious level, narcissistic individuals are very familiar with the concept of mirroring. They use people as mirrors all the time. So this is a fairly egocentric image, and we can use the image of a mirror or the image of masks as a way of beginning to evoke and move to ego-dystonicity the false self or as-if structure, making it less integrated, less tightly held onto. And one of the ways that we can do this is by having the person experiment in the transitional space of hypnotic trance with the understanding that the mirror image is a reverse image of reality. Okay? We all know that things are reflected in a mirror in the reverse way they are in real life. I remember in introductory psychology in college many years ago, there was a laboratory experiment where you had to put your hand into a box and, looking at a mirror reflection of your hand, trace inside the boundaries of a star. And one of the things that you learned was, in order to stay within the boundaries of a star, you had to move your hand kinesthetically opposite from what it looked like it was going in the mirror. And it was really a very curious thing to get used to. Well, you can use this kind of imagery with narcissistic patients to get them in touch with the idea that the mirror is the opposite of reality, in anticipation of the eventual interpretation of the false self, where the entitlement, the grandiosity, the apparent sense of omnipotence is really the opposite of the authentic feelings of emptiness and inadequacy. But unlike trying to interpret this defense in talking therapy, where the affect which comes forth is so negative that it leads to a negative transferential devaluing of the therapist, because in that instance, as you have empathized with the authentic self, you have injured the false self, and you become not someone who's experienced as a friend, but someone who's experienced as a kind of enemy. In hypnosis, because we can regulate the intensity of the affect, as the person begins to feel anxious, we can have them let go of the image of the mirror, restore a sense of comfort and calm, and then come back to it again. The same is true with masks, how masks can distort images. But people learn early on that the mask is not the true representation of what's behind it. And you can evoke people's memories of Halloween masks, or dressing up for a play, or experimenting with face painting, or being at a masquerade party where they encountered a friend who initially they didn't recognize because she or he was wearing a mask, as a kind of experiential referent for the fact that what we see on the outside is not always the same as what is behind it. And this kind of imagery play, while managing the anxiety around it, can gradually begin to dilate the false self-defenses of the narcissistic spectrum individuals. So when I'm going to be doing hypnosis with one of these folks, regardless of what other utilization I may be planning to employ, I'll begin the session by doing some mirror play or working with masks in trance, the imagery around that, to sort of dilate a little bit the false self for that particular therapeutic intervention. Okay? But when you do that, you have to also provide some sort of reassurance that what is behind the mask is okay to see, okay to feel, okay to be. And that just as two friends who share a secret feel closer by that confidence and bound by that intimacy of knowing, so the sharing of what is behind the mask or inside the mirror can increase the sense of comfort and closeness in the alliance between you and your patient. Yes?
Is there another difficulty to start with such things as maskers and mirrors for patients who have probably other complaints? You have to explain why you are doing such exercises. Is that not difficult?
Well, you know, what's interesting to me is that I typically do not explain that in advance. That is, I say, we're going to be doing some hypnosis today. We'll work with some images that I think will be helpful in our work. Okay? So then we start the trance. Now, sometimes patients will remember the mirror. That's not the only thing that I might do in that hour. You know. Sometimes people remember the mirror work when they wake up, and sometimes they don't. I usually say to my patients, you'll remember as much of what we've done today as you feel ready and able to work with now. So I respect that, and I usually don't bring up the mirror and mask work until the patient does. And when the patient says, you know, today for some reason I remember looking into a mirror and feeling really weird, then we work with it. But often it comes up as something they're curious about, not something they want to know, what does this have to do with working on my problems with my wife? And then we explore. We'll wonder what that means. Wonder what those feelings are about. And isn't that interesting? And let's see what we can understand about that together. So I have never had a patient who said, why do you do that? And it's kind of interesting because what I have found oftentimes is that when people hear me talk about this work, or see me working on a tape with a patient or in a demonstration, they'll sometimes say, well, how do your patients feel about you saying things to them like, and your hand is still at the end of your arm, and it's your arm, and it's your hand, and your right hand is still your right, and your left hand is still your left. I mean, don't they think that's weird, talking to them like that? That sounds kind of like a curious way of talking with patients, not like we would normally talk with them in waking psychotherapy. And what I'm reminded of, for those of you who are not from the United States, you may not know a television person named Mr. Rogers. But maybe some of you have seen him. He has a children's show. And his program is addressed to sort of 3-, 4-, and 5-year-olds. A lot of my friends, including myself, the first time that I saw Mr. Rogers, I thought he was kind of a nerd. I didn't like him very much. But my son, when he was about 3 years old, became very attached to Mr. Rogers. And every time that Mr. Rogers came on, he was glued to the TV set. And Mr. Rogers would come in and he would put on his sweater, and he would put on his special shoes, and so on and so forth. He would do the same thing each time, and he would talk in a particular way about his neighborhood and so forth to the children. And I think the reason that the children liked him so much and the adults thought he was kind of nerdy is because what he did was address specifically to the child. The same is true with our patients when we are developmentally focused correctly in trance. Then what happens is that they resonate. It's like, you wouldn't feed your adult company baby food, but you wouldn't feed your child a steak. And so we want to developmentally focus and target for our patients at the level that they can understand and utilize and metabolize what it is that we are presenting. So in talking about mirrors and masks with narcissistic spectrum patients and using that imagery in trance, I find rather than their being sort of uncomfortable with it, that they resonate somehow with this notion because it's part of the phenomenology of their relationships. And what you have to be careful about is to contain and neutralize the affect that begins to come forth once you've done the hypnotic imagery. But the imagery itself is not disturbing to them in my experience. Okay. Well, we have about 5 minutes left before we break for lunch. Do you have any questions that you'd like to ask? Yes.
You sounded as if you just announced that today we're going to do some hypnotic work. You don't ask them to do it. Why do some hypnotic work?
Usually, I have reached a contract about including hypnosis before, and we sort of plan the next time you come, we'll do some hypnosis unless something else comes up and so forth. Yes?
Can we see the film after those?
You would, at first, when I asked, most people wanted to stay and watch it now.
Well, maybe they want to stay before lunch. They want to see it before lunch.
So we can vote. How many of you would prefer to stay and watch the videotape, which will be about 45 minutes, and then break for lunch? Raise your hand.
What's the tape about?
How about coming back early from lunch?
Well, that'll be the second choice, okay? 1, 2, 3, 4, 5, 6, 7. How many would prefer to go to lunch for 45 minutes and then come back and see it before our afternoon session? 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay, that wins. So what we'll do is we'll take a break of about 45 minutes and come back about 12:45, and then we'll have time to look at this videotape before we start at 1:30. For those of you who are not decided whether you want to watch it or not, this is a upper borderline patient who has some secondary narcissistic defenses, who I saw in consultation while he was in the hospital after he had lost control and beaten up his mother, broken her jaw. And we're working on issues of affect regulation and impulse control, issues of self and object constancy. And because he actually was the patient of another therapist, we were working on restoring a sense of alliance with her, since my understanding was that this had occurred as a kind of acting out of some uncontained negative transference, maternal transference, towards his therapist. So that's what this session is about. Incidentally, for those of you who have not seen Dr. Fromm come in, she is in the back of the room, and as I mentioned earlier, she'll be joining us this afternoon. you. Okay, so those of you who want to see the film, back at 12:45, and those of you who are just coming back for the afternoon, back at 1:30.
At the Congress in Melbourne, and it's been submitted for publication in major journals. If I may have the first point. Sorry. No, it's okay. No, I think it's maybe no, it's okay. It's just an outline. I'm sorry, I cannot hand out because my handout went lost on my adventurous flight from Europe to the United States. Of course, we know that the psychoanalysis view neurotic symptom as external manifestation of underlying conflicts. And this conflict can be solved by the lifting of the repression, the achieving of a full cognitive and emotional insight. So the hypnoanalytical technique are procedure practices with hypnotic modality which are aimed at the same principle and the same goals of psychoanalytic therapy. So they share the psychoanalytical principle that symptoms are generally the consequences of intrapsychic conflicts. So any treatment which works by overcoming resistances and interpreting transferences can be considered psychoanalysis. This despite the rejection of Freud, who usually discarded the hypnoanalysis as a variant of psychoanalysis. So there are similarities between psychoanalytic and hypnoanalytical goals, but there are some differences in therapeutic techniques for achieving them. In the past, hypnoanalysis was discarded by Freud mainly because it was assumed that it could bypass the ego. It would be somehow superficial. But we know from recent clinical and experimental research that hypnoanalysis can also have a kind of reconstructional goal. It aims at the same principle of reconstructing personality, not only at suggesting something to a person in order to remove a certain symptom. And so it may have some advantages toward psychoanalysis. For instance, one of the crucial points, in my opinion, is ego-receptivity. We know that in the trance, we may vary the depth of trance depending upon what stage of hypnoanalytical treatment we are on. For instance, we may take advantage of deeper stage of trance in the first phase when we need uncovering unconscious conflicts, because in this stage we need the patient to regress possibly and to let us uncover unconscious conflict. But of course, if the patient is in a deep state, his ego participation is rather low. It's not so high. So in the later stage of hypnoanalysis, we may want to make more superficial the level of hypnoanalysis in order to produce egotization. We mean a participation of ego. We want to surface the unconscious conflicts to the level of awareness. And so we may vary the optimal trance depth in therapy according to the stage in which hypnoanalytical work is on. This is a major advantage toward hypnoanalysis. Other main advantages of hypnoanalysis toward psychoanalysis are that it facilitates the rapid uncovering of the repressed material. There is some experimental evidence that by using hypnoanalysis, the Freudian pre-association may be enhanced by about 65–70%, as comparing with the traditional psychoanalytical method. So it is advantage. Moreover, with the hypnoanalysis, we can also not only associate ideas, as in the psychoanalytical paradigm, but we may also more effectively associate affects, feelings, moods. And for instance, a variant of the reaction formulated by Hill and Watkins is the so-called, by John Watkins, is called affect bridge, which is a way to associate moods and affects rather than idea. But why we should choose to associate moods or affects rather than ideas? One reason may be when we are not able to locate in space and time the origin of the possible traumatic event. Whenever it happens, we may try to regress the patient with the same mood at the first time when he expressed that mood. And when the patient is regressed at that time, it's much easier to associate mood with ideas, because moods or affect have a great power to condense unconscious conflicts, to condense ideas, to displace and to discharge also the unconscious conflict. This is a peculiarity that the hypnoanalytical treatment has toward the classical psychoanalytical approach. As mentioned many times in this workshop, it leads also admirably to the development and the analysis of a transferent relationship, because hypnosis is a very powerful catalyst of the transferent relationship, and so it can speed up the therapeutic process. And at the same time, it may facilitate the dissolution of the transfer resistances of what has been called as transfer neurosis, for the same reason, for I mentioned before, development of transference relationship. But there are also some disadvantages, in my opinion, by using the hypnoanalysis, particularly some kind of hypnoanalytical procedure, and I'm thinking particularly at using a regression technique. In my experience, the applicability of hypnoanalysis is generally restrained to those individuals who can attain deeper stage of hypnosis. Otherwise, it would be very difficult, or in my opinion, sometimes impossible, to have a regression, or particularly a revivification, which is much more effective than regression, that can be very useful to uncover unconscious conflicts and work through them. Another minor disadvantage, which is common to other kind of approaches, but is maybe more important with hypnosis, that it requires an adequate control of the counter-transfer by the therapist because of the very strong relationship transference, which is particular to the hypnotic relationship. So this, in my opinion, can be some of the major and minor pros and cons toward the use of hypnoanalysis as compared with psychoanalysis. The second point I would like to focus your attention is the ego state hypnoanalytical technique. It is it's a variant of traditional hypnoanalytical technique. It may be considered rather a sophisticated one. It has been formulated and developed extensively by John and Ellen Watkins, but really the theory, the basic principle of ego state stands by the original work by Paul Feller in the 20s, and also by an Italian psychoanalyst, Eduardo Weiss, which in Trieste was one that first introduced psychoanalysis in our country. And I just want to outline some basic principle as formulated by Watkins, and then to mention some technical principles of application. As discussed extensively by Dr. Baker, personality develops through two basic processes, which is differentiation and integration. Of course, the separative function exists on a continuum ranging from normal adaptive differentiation and through defensive mechanism to maladaptive dissociation, with it is at the other extreme of the spectrum. So, what are ego states? They can be considered as a complex configuration of psychological elements that may be integrated into a single discrete pattern within the individual. This pattern is an organized system of behavior and experiences, not only ideas, not only moods, whose elements are bound together by some common principle and separated by other such entities by a boundary which is more or less permeable. So it's a very complex pattern which is cognitive, affective, perceptual, so very complex. Of course, we can have different type of ego state. I just mentioning some of the more common. One ego state can be organized around being a child. Another one can be organized around the concept of reaction to authority figures, as maybe the subject can have introjected some significant individuals, such as father or mother. Of course, the ego state has some similarity with other, theoretical formulation. I'm thinking, for instance, to the metaphor of the hidden observer, coined by Ernest Hilgard, after some initial experience with acute pain during hypnosis. And it was the discovery of a sort of called hidden observer, a metaphor for meaning and hidden cognitive structure which is within the hypnotic ego and which can be elicited through some kind of hypnotic technique such as automatic handwriting or automatic speaking. This hidden observer is separated by from the hypnotic ego, and the two are not communicated, so the boundary can be really impermeable. This is one of the principles by which we think that hypnosis can be effective in inducing analgesia, because one of the theory assumes that hypnosis can split two main characteristics of the pain experience. One is the sensory discriminative dimension, which attains to the characteristic of the stimulus, pain itself, and other is the motivational affective reaction, which can be defined as suffering or pain reaction. And splitting these two components of the pain experience, the patient, the subject, could still retain the experience of pain, but the pain is not such an invasive experience as it usually is. It will say, well, I feel my pain, but the pain is not so close to me. It's a sort of separateness from the experience of pain, which is very important for some kind of chronic pain. Hilgard, from these experiences, formulated a theory of multiple cognitive control of egoic substructure under the dominance of overall ego, and these egoic substructure can be rearranged in their hierarchical organization by means of hypnosis. The same approach that the ego state therapy formulated. But another similarities with ego state is between ego state therapy and transactional analysis by Eric Berne, which formulated briefly three stereotype substructure: the child, the adult, and the parent. The difference is that in the ego state theory, there are not only three subtypes of personality, but many. It's a broad spectrum. So it's much more flexible and much more systemic in the approach. Which are the main characteristics of this ego state? The ego state, as it appears clear, should be regarded as fragments, as segments of a person, as a part of a person. And another interesting characteristic that except in DID, or multiple personality disorder, they do not appear overtly unless hypnotically activated, the so-called covert ego states. And the hidden observer is one of the proof that this ego state must be elicited through hypnotic means, otherwise they could not operate overtly. Of course, they are often in intrapersonal conflicts with one another, creating tension, anxiety, psychosomatic symptoms, and maladaptive behavior, which may be considered as the origin of the ego states. According to Feather and Watkins and others,
there may be three major possibilities. One is a kind of physiological, normal, adaptive differentiation. We learn to, as in a society, everyone has his own task. In a person, every ego state may be in charge of addressing some special demands from the reality. But in some cases, this differentiation may be compromised, may be insulted, and the consequences may be dissociation and the origin of ego state with boundaries which are not any longer permeable and flexible, but become rigid and impermeable. Another cause may be psychobiological trauma. Splits may be caused by traumas. Dissociation is one of the most common defensive mechanisms against psychobiological trauma. Of course, I listened very carefully what Dr. Baker said this morning, that dissociation is also a kind of splitting of the self, and so may have a kind of disruptive consequence. But I think also that dissociation sometimes can be an adaptive evolutionary mechanism. If I cannot stand my anxiety, I cannot try to be here. And so dissociation can be a way to escape. I think that some kind of, for instance, animal hypnosis resembles some kind of escape behavior. It's kind of freezing reflex. So, of course, dissociation may have different meaning, but in some cases, it may have also a kind of adaptive meaning. Another possibility is, of course, the introjection of significant individuals, the so-called parent ego states. When the child introjects a figure of a significant, maybe his father or his mother, he feels, he behaves like his mother and his father, and this may become an ego state which may become executive in that person and may take the lead in that person.
Two slides ago said that the ego states don't appear overtly unless hypnotically activated. Can that be self-hypnotically activated also?
Well, I cannot exclude that. There are some kind of self-hypnosis that can, but in people in which self-hypnosis occurs spontaneously, I think in my experience there are some kind of similarity with DID disorder, multiple personality disorder, in which the splitting is a way, because dissociation it's intrinsic not only to hypnosis, but multiple personality disorder. So if this occurs spontaneously, I would suspect. So, which are the therapeutic consequences of this principle? The ego state therapy is the use of group and family therapy techniques to resolve conflicts between the various ego states, which we may assume that constitute a sort of family of the self within a single individual. So therapy may be directed toward this part person, this fragment person, represented by the ego states, and rather than toward the whole individual, at least in the first stage of the hypnoanalytical procedure. It is preferable to deal with ego states under hypnosis rather than the wake condition for the above-mentioned situation, because ego states do not usually become overt spontaneously unless in multiple personality disorder. And so, what Watkins called hypnoanalytic ego state therapy is the activation of ego states in hypnosis, accomplishing by inquiring the hypnotized subject, for instance, asking him, there is a part of you that knows something about the cause of your symptom. We can use ego state, as we talked yesterday with Colin, for diagnostic and prognostic purposes. There may be an ego state, a part person that can know something about the cause of suffering of the whole family of the self. For instance, in the classical experience by Hilgard, which led to the discovery of the digital observer, Hilgard was studying hypnotic deafness in a student in front of many other students, and when the subject was deeply hypnotized, he asked him, though you are completely deaf, in hypnosis, as I suggested, there is still a part of you that is registering what I'm saying, and if it is so, can this part lift the finger up? And this happened. And this happened, and when the subject was awakened from hypnosis, he was not aware of this unconscious movement of his finger. That meant that the ego state that controlled the movement of the finger was completely isolated from the hypnotic ego. So this was a demonstration of the presence of the ego state, which are separated each other. The advantage of hypnosis in doing this, apart from the fact that it is preferable using hypnosis for eliciting ego state, is because hypnosis is a focusing procedure which enables to ablate temporarily all the other ego states which are not relevant for our research, and to concentrate on the ego state which can be considered responsible for the problem we are dealing with. And after uncovering with this technique the unconscious conflict underlying the symptoms, a strategy of constructive suggestion, exchange of communication between this ego state, and reconciliation between the various ego states is then formulated, just as in a therapy, in family therapy. So I want to just to briefly outline some very elementary principles of this rather peculiar way to approach psychological and psychosomatic problems with hypnoanalysis. I will now skip to the third topic of my presentation before entering in the major part on psychosomatic disease, talking about using of hypnosis image in hypnoanalysis. Since my training is also a neurobiological one, I would also mention some reference from the literature referring to the use of why using dreams or images or fantasies into hypnosis. Well, images, fantasies, dreams, and hallucination can be considered also, if the data are not univocal, as mainly as a right hemisphere correlated phenomena. So they are linked, they have only one, a neuroanatomical crossway, main crossway. They are primarily generated from internal stimuli, brain activity, and generally experienced as visual sensory experience, not only visual, but mainly visual. We know that there are good correlative studies suggesting that there is a positive correlation between the development of image and absorption and hypnotic susceptibility. That means that the higher hypnotic susceptibility, the higher the capacity of developing image, dreams, and fantasies. Which are the similarities and the differences between image, fantasies, dreams, and hallucination? Fantasies are subjective experience censored by the subject as being self-created. Dreams and hallucination are subjective phenomena, but experienced usually by the individual as external objects. Except some particular dreams, like lucid dreams, which are a special part of dreaming, but very rare. Images and fantasy generally occur during normal state of consciousness, whereas dreams and hallucination appear during some altered state of consciousness, such as sleep, deep trance, or psychotic situation. So there are some similarities and some differences. As a consequence, images and fantasies are more likely to occur during the lighter stage of trance and seems to be guided mainly by secondary conscious or preconscious processes. Whereas dreams and hallucinations are experienced more often in deep trance and are more likely to be the expression of primary unconscious processes. So we have two different ways to use and two different meaning of communication in these experiences. After the superego is inhibited, there is progressively less ego activity, and dreams are more likely to reflect, as I mentioned before, primary process. As a consequence, this may explain why, when the dreamer awakens, they are more likely to forget the dream experience. I will just mention the major psychoanalytic paradigms of dreams. Of course, dreams deal with, according to Freudian, the first Freudian paradigm, dreams deal with unresolved, unconscious childhood conflicts and represent a primary wish fulfilling process. But not only the dream is concerned with the past, with very past experience, but may concern also with current experience, with current conflict. And this is the more recent formulation by Erika Fromm and French in 1986. Dream has also an ego function and a cognitive structure, expression of a current focal conflict. So it may be considered as in terms of problem-solving self-therapy mediated by the dream. And this can have implication for using as therapeutic tools. Of course, there are some definition dreams as the protector of sleep by Freud, the road to unconscious, but also some other that are maybe less known, like the third one by Paul Sacerdote, who has extensively used hypnotic dreams, who define the dreams within the therapeutic set as an internalized or externalized communication. And finally, induced dreams, which can be nocturnal or hypnotic or both, can be a powerful tool to induce therapeutic change. The slide refers to the Freudian paradigm, which is very well known. I just will briefly comment. According to the Freudian theory, the residual experience of the day may give rise to unconscious wish, which is under the control of censorship and which represent the manifest content of the dream, of the wish. But in order to this unconscious wish to be surfaced to the consciousness, it needs what Freud called the dream work. It needs to be elaborated by means of different mechanisms such as condensation, symbolism, displacement, or substitution. And only so, the concealed wish, which is the latent content of the dream, can come to the level of consciousness, they become conscious at the dreamer ego. There is very often some kind of confusion when we are talking about hypnotic dreams. What does it mean, hypnotic dreams? And I think that this definition by Sacerdote may give an answer. I agree with this definition that says that dreams during or under hypnosis are hallucinated visual and multisensory experiences which occur after sleep suggestion given during heterohypnosis have been executed and within the period of suggested sleep. So that means that hypnotic dreams must be some kind of analog of nocturnal dreams with the same pattern of occurrence. It is not possible to have dreams unless we are in deep sleep, in the REM stage of the sleep. There is only one situation, which is narcolepsy, in which the subject abruptly falls from the wake state into the dream state. But it's a pathology of the encephalon or the thalamus.
Excuse me, I don't understand after sleep suggestion.
Yes, it would be clear in the next exposition of this presentation. But that means that in order to speak appropriately of hypnotic dreams, you have to make different steps. The first step is to induce in the trance, I will give an example when I will talk with the technique, a suggestion of sleep. And when, and only when the suggestion of sleep has been accomplished by the subject, you can give the suggestion of dream. You have to recapitulate, I would say, the same occurrence of events that as in the normal nocturnal dreams. Otherwise, these hypnotic dreams can be some kind of imagery state or dreamy state, but not some kind of reverie, but not really hypnotic dreams. Of course, there is a lot of of discussion and controversy whether hypnotic dreams are the same than nocturnal dreams. I don't want to go into this controversy. In my experience, there are some similarities and some differences. Usually, hypnotic dreams last much less than nocturnal dreams. But the psychodynamic content of hypnotic dream may be the same, and that is relevant for therapeutic purposes. So there are the differences. For instance, there are some authors that describe during hypnotic dreams, dreams during hypnosis, the same rapid eye movements that can be observed during nocturnal dreams. I've never observed such a phenomenon. Sometimes there can be some kind of movement of the eye that can resemble REM stage, but never they are REM stage really. So I think there are some kind of phenomenological similarities rather than ontological similarities. Which is the rationale for a therapeutic use of dream in hypnosis? From a neuropsychological point of view, experimental evidence suggests, as I mentioned before, an increased right hemispheric activation in hypnosis, imagery, and dreaming. So we can use the same communication pattern using hypnosis and dream. On a psychodynamic basis, hypnotic dreams enable the patient to gain access in a symbolic manner to his inner life, to unconscious conflicts, and to self and object representation. Thus, historically, the first rationale in the therapeutic use of dreams deals with diagnostic functions. But as I will say in a moment, there are not only diagnostic functions, but also some therapeutic functions. Main advantages of the hypnoanalyst over the psychoanalyst in dream interpretation, because the hypnoanalyst may be more directed. He can not only wait when the subject would present a dream and interpret the dream with the patient, but he can direct induce the dreams that interpret in trance or in the wake state, can do a lot of things that they will say in a moment. Dreams can be also a useful indicator of the state of transference, reflecting positive or negative transference. And finally, they can be very useful in monitoring the therapeutic process and forecasting change. In my experience, there are many patients that in the final stage of their therapy have some kind of dreams that foresee in a very, very precise way the outcome of the therapy. It's, I would say, kind of self-efficacy or outcome expectancy in the dream state rather than in the wake state. So, diagnostic and therapeutic tool, I call it the healing dreams, because we can use dream as not only as the only tool, but as a very important tool for inducing a change in hypnotic treatment. Which are the main advantages of inducing a dream in hypnosis? We can induce a dream during hypnosis and dreams that the patient reports immediately after they are dreamt. We have a wide variety of possibility, as in part Dr. Humphrey mentioned yesterday. We can also suggest that the patient dream out a particular conflict or a problem that the therapist can work through. And again, we can suggest the patient to dream again, shaping the content of the dream. We can modify, as in a TV set or in a theater, because we can, one of the axiomatic paradigm about dreams, and the dream cannot be changed as spontaneous self-activity, which is not true, because for hypnotic dreams, it is definitely true that you can change the setting of the dream, and this is also partly true for nocturnal dreams. You can induce some kind of change in the nocturnal dream the patient is going on to have next night or one of the next night. We can also suggest the patient a delayed understanding of the symbolism and meaning of his dreams whenever he's not capable at that time to interpret the dreams. We can also use hypnotic dream hypnosis to enhance the recall of all nocturnal dreams previously repressed. It can be quite easy for a patient that says, usually I forget or I've forgotten my dreams during different sessions to enhance the recall of previously forgotten dreams. And finally, post-hypnotic suggestion to have nocturnal dreams or to remember forgotten or repressed dreams. We can use all this technique on a different basis or combined together. Now coming to the techniques, this is one of my preferred technique for inducing hypnotic dreams. First of all, I induce the trance and I proceed with deepening of the trance. Then I induce an easily natural sleep, giving suggestion of metaphor of sleep, such as mentioned yesterday by Dr. Humphrey, Anthony Mears' suggestion of sleep. And while asleep, the patient continuing, this is important, to be in contact with the therapist by, for instance, ideal motor signaling, will be instructed to have a pleasant, interesting dream. This is a very important issue. It has been suggested by many authors, including Milton Erickson, that it's better to suggest at the beginning a dream with a pleasant content. Ideal motor signaling will communicate the end of the dream. The subject will wake up from the dreaming state, from the hypnotic sleep, and from hypnosis, and then he will clearly remember the dream. This is the process in normal induction of hypnotic dreams. What happens if the patient fails to produce a dream? It happens very often at the beginning. The suggestion is repeated over a number of sessions in a slight modified guise. We suggest the patient in a modified way to dream the same dream. Redream is not necessary, it's not sufficient sometimes. Sometimes we have to change something. Sometimes the patient is asked to report his dream to the hypnotist while still in deep trance, in order to bypass the censorship of the secondary process. If it is possible, I prefer this kind of techniques because it allows the therapist in the initial stage of the hypnoanalytical process to go on with working through bypassing the censorship of the secondary process. So we put the patient into trance, we induce the hypnotic dreams, and in the next session we modifying the dream, we interpret the dream with the patient into the trance. And so it allows an advantage because we bypass all the resistances that possibly or probably the patient will have in the wake state.